So at the outset, I'd like to thank Dr. Twinkle Shah for making me part of this course. And I think year after year, he's been presenting so wonderfully in all these AIOS programs. And his course has really been one of the most rewarded series now. So I'm really sorry for my commitments in other places. So I'll talk on just a second. Yeah. So special cases, long eyes, short eyes, and post-vitrectomized eyes. Twinkle, is my screen visible and am I audible? Twinkle?
Yes, sir.
Yeah, you are audible.
Visible or not? Okay. So we all know that the measurements in cases of IL-PAR calculation basically boil down onto biometry and the keratometry readings, be it a topographer or maybe any of the corneal measuring devices, an ordinary keratometer. Sources of errors in IL-PAR calculation. Of these years, we've been thinking that the axial length, maybe the keratometry readings, and maybe the others, maybe the ocular surface, are the major causes where there is an error in IL-PAR calculation. But believe me, it's the effective lens position which is the major attributor to all errors in IL-PAR calculation. So it basically boils down to the formulas where you need an ELP to be calculated accurately. Then comes the role of the axial length, the keratometry readings, and the other sources of errors in IL-PAR calculation. So optical biometry, we all know, is very accurate. It's no longer a significant source of error. The axial length by an ultrasound gives an average of plus minus 0.20, whereas by the laser interferometry, we can have an error of plus minus 0.02 millimeters. Now, if you see here the extreme bar on the right side with a partial coherence interferometry, you see a straight bar which is standing right on the zero, whether it's a myopic or a hyperopic patient, whether it's a abnormal axial lens. So you get an accurate axial length calculation. Compare vis-a-vis the immersion A scan, you see there could be a fumble on the -1 or +1 side, and more so with an applanation A scan where there is falsely short axial length. There is, because of the variable corneal compressions, microabrasions, high operator dependency. So gone are those days of an applanation. In other days with an partial coherence interferometry or maybe an immersion A scan. Keratometry, we all know, stands next to the IL-PAR calculation, and very important is taking two keratometry readings maybe sometime apart, and be sure to identify the post-LASIK patients, which I hope will be discussed or maybe will be discussed. So the biometry in the IL-PAR calculation, because small biometric errors can induce high post-operative refractive error, in cases of, that's why you prefer an optical biometer over an ultrasound. If you see here, the accuracy with an applanation is close to plus minus 0.24 as against optical, which is almost bang on target. And the ELP, as I have mentioned, is almost 35 to 40% a source of error. And the axial length attributes to almost 17% to 36%. And this is what is a publication in the JCRS 2002 by the Olsen et al. So the classification of the IL-PAR calculation formulas, we all know the Vergennes formulas, they differ in the way the ELP is calculated. You can have the historical or the refraction based, the regression, the Vergennes formulas with 2 variables, 3 variables, 5 variables, or the 7 variables, and the artificial intelligence, which is now new to the industry with the Clark neural network, the Hill RBF, and the ray tracing, the Oculix and the Ficortex Olsen methods. Now, when you talk about the short and the long eyes, the various formulas, so boil down into, for the short and the long eyes, maybe the formulas that you read, the Holiday one, the Hoffer-Q, which are very specific for short, and Sargeti, Hagees, Holiday, Olsen, Barrett 2, and the Hill RBF, maybe for the long eyes. Now, what happens in short eyes? The key for accurate IL-PAR calculation in short eyes is the accurate measurements and adequate IL-PAR calculation formulas. And yes, even after all this, we all know there is a big defect in the IL manufacturing standards where you have an almost variable of plus minus 1 diopters for IOL power as more than 30 diopters. So that means even if you calculate an IL-PAR close to maybe 35.5, but the industry yet has to offer you maybe a 35 or a 36 diopters, because the way they sort out the lenses, still it's a deviation of plus minus 1 diopters. So the axial length, so in shorter eyes, basically an axial length and the ELP are the two major errors. So errors in axial length, AXL measurements have a very high impact, and an accurate production of ELP is very important in these short eyes. So if you consider an error caused by 1 millimeter of a compression of an eye, an average eye would have an error of 2.5 diopters. And this may be exaggerated in short eyes to the tune of 3.75 diopters. Now, this is where in shorter eyes, the power calculation error boils in. And in the long eyes, it may be as low as 1.75 diopters. Now, when you have an error in the ACD, I think my slide is, I'll just take a minute in here. So an error caused by an, I'll just take a minute. So when you have an error which is caused by an anterior chamber depth mismeasurement of 0.25 millimeters, in cases of long eye, maybe eyes more than 30 millimeters, you have an error of 0.1, and this error can be increased to almost 0.5 diopters in cases of shorter eyes. So basically, an accuracy of axial length and an ELP is the two crux when you are dealing with the short eyes. And these are two major sources of errors in IL-PAR calculation. So the short eyes, if you have an IL master, or you have a lens star. For the lens star, we basically depend on the Olsen formula or the Barrett, Olsen OLCR, or the Haigis or the Hollade one. But with an IL master, I think Barrett's Universal 2 formula is one great choice. You can have Haigis and Hollade one. So in my practice, I would take a multi-formula approach where I would take 4 formulas and then get an average of all the formulas. But I would trust Barrett's Universal 2. So this is a nice paper where there has been a meta-analysis of an accuracy of intraocular lens power calculation formula in short eyes, Chinese paper by Dr. Wang et al. And this basically concluded that the overall incidence from the studies confirmed the superiority of the Haigis in cases of short eyes over the Hoffa-Q, SRKT, and the SRK2 in predicting IL power in short eyes. Another beautiful paper by Robert McLaren, Biometry and Formula Accuracy with Intraocular Lenses in Extreme Hyperopia. They again said this is the largest published series to date of biometric predictions for cataract surgery, and they confirmed the Haigis formula to be the most accurate. A consistent difference between the open loop. This is one very important point I want to highlight whenever we are dealing with short eyes. The lenses may be an open loop and a plate haptic lenses. There is always a difference. That means the haptic design always has an influence on the effective lens position, specifically when we are dealing with very small eyes. So this is one very important factor to choose the right type of lens when you're implanting in very short eyes. Now, when you're high myopia or maybe an eyes with high axial length, it is basically this again a paper from Elvin Chang, which says there is an improved predictive results with the Barrett Universal 2. So I think Barrett Universal 2 still holds true for extreme of the axial lens, high axial lens, and still you can have Haigis, SRK2, Hollade 2, and the Olsen formulas. So if you see, this is a beautiful pictorial depiction. On the extreme left, if you see those bars, this is the Barrett, the Olsen, and the Haigis. Now, if you see, the red is the extreme, the high axial lens or the high myopes. Blue is for short axial lens, and the green is for range between 22 to 25. So if you see closely, the bars are very minimal. That means the prediction errors is very, very less when you are talking for Barrett, Olsen, and the Haigis. So I think these three formulas hold very strong when you're dealing with the extreme of the axial lens, maybe the short, long, and even in the normal eyes. And if you see on the extreme right, these are the rest of the formulas where there is a high degree of error when you're talking of high axial lens. So Barrett, Olsen, and Haigis are the three formulas when you're dealing with the extreme of the lens. Again, if you see here, the central red dotted line depicts the normal axial length, maybe between 22 to 24, 25 on the extreme right. Am I audible? Hello?
Yes, sir. Yes, sir.
Yes. Carry on.
Hello?
Hello. Yeah,
Am I audible?
Yeah, you are audible. Sonu, you are audible.
Okay. So on the extreme right is the Twinkle, am I audible?
Yes, sir. Yes, sir.
You are audible.
Thank you.
Continue.
Okay, thank you. On the extreme right, you see an axial length between 25 to 30, and on the extreme left is less than 22. So if you see, the Barrett and the Olsen formula have straight they are depicted by the red line. So they stand true for all the variability in the axial length. So that means whether it's a short eye, long eye, or maybe a normal eye, these are the universal formulas which can be taken into consideration. Just a quick word that I would share when you're calculating IOL calculation in the phakic IOLs. Now we have a lot of patients where we have done ICL implantation and you need to calculate out the IOL power. So I think I just wanted to touch up the last slide. And whenever you have an ICL or an artisanal or a sachet or a vivante inside the eye, basically the axial length is shorter than the real. That means when you calculate, it is shorter calculated than the real, and hence there is more power which is required, and there is always a post-operative refractive error of lens up into a myopic refractive error. As compared to if you have a silicone material inside the eye, the axial length calculated is slightly longer than the real, and hence the less power which is required, and you end up into a hyperopic power shift. So I would just like to thank here and thank again Twinkle Shah for making me a part of this course, and I would really apologize for late entering into the course. Thank you so much.